And thank you very much for the invitation to come and talk to you about this, because it's exciting. It's an area that we're doing a lot of work in at the National Clinical Programme at the moment, and so it's great to come and let you know what's happening, some of the things that we've learned in the last year or two, and maybe how they're useful in the armoury for heart failure patients. Early on, the National Clinical Programme recognised that if you were really going to improve the quality of life for patients with life-limiting illness, you'd really have to identify their symptoms early and impeccably assess those symptoms, because only then could you develop a really individualised and excellent care plan. But to do that, we'd have to have some sort of a standardised assessment tool. Up until then, we didn't have one. And so this national tool was devised, and it can be used by anybody in any setting, which is good. And of course, with that had to come a support for staff so that they could build the confidence and the competence to be able to use the tool appropriately. So about 2 years ago now, the tool was developed, and it's based on the palliative care approach. It incorporates the 4 domains of care: the physical, psychological, social, occupational, and the spiritual components of care. And with it came some education resources. So you have the guidance document, and that should be in everybody's pack. If it's not, I brought some extra with me today because the crowd is bigger than had been anticipated initially. There's an A3 poster that can be downloaded, and it can be put up in your clinic room or your consultation suite, wherever you think it's appropriate. And there's a PowerPoint presentation that can be used back at your workplace to inform people about this palliative care needs assessment. Just on the guidance document, I just want to point out a couple of things to you on it. It specifies, and some of the conversation I want to specifically specify, people that this applies to, the patient group. It's any patient with a life-limiting illness that's progressive, that's fatal, and it's not going to be cured with treatment. And that really takes in a huge array of patients, and it's important to say that because in the last talk or two there was talk about palliative care being for cancer patients only. That's come up again from practice this summer to us in the national programme, so it's important to say that. It can be used by any staff, and that's any health or social care staff and care assistants, and that's really important. It can be used in any setting, and it gives prompts to you about the type of assessment that can be done in each of the 4 domains. It's all in that. All of these documents, they're available. The website is there, it's listed on the bottom of the page, and then there's a tiny little bit of writing on the bottom, and I think that's very interesting. It's from the implementation science people, and they say if you do a tool like this and put it out there and hope that people pick it up and use it, you'll have about 14% uptake in 17 years. So that's not very good. So of course we had to develop a support programme to go with the tool. The palliative care programme took a brave decision, really, not just to introduce an education programme, but to introduce a person-centred approach to implementing this into practice. And I was going to say that that's an emerging approach, but in fact it's not, because when I think about it, the Mater Hospital here 10 years ago adopted this approach when you were looking at, for the very first acute hospital in the country, looking at acute indicators for quality in nursing care. But it is a bit different. It very much focuses on that engagement with the patient, what they really want as well as what they need. And Regina, it'd be interesting to talk to her about that, the want and need. But the approach focuses on staff as well, what the staff want and need, the skills that they need to be able to do this properly, but also the culture that they work in and the care environment that the staff work in. And so it focuses on the patients and on the staff. And that is a little bit different, and you don't just go and learn that and then do it. It's an approach that has to be facilitated. And so from the programme's point of view, they role modelled it, and that's what they did. An expert nurse and expert doctor took 72 people from around the country, all different disciplines, different settings. There's a list of them there in the box. The participants, it was effort for them. They had to do 2 online lessons with the theory in that about palliative care approach, person-centred care, and some theory about facilitation skills. Then they came to a 2-day workshop, and there they had their assumptions and the norms about their current practice and what they thought was person-centred. And they unpicked that and did exercises to help them make it more person-centred. There was a bit of homework involved. They had to do a reflective piece. And before they left, they were given an action plan so that they'd be able to get started with very real expectations about what to do when they go back into their workplace. This bespoke programme was accredited by the NMBI and the College of Physicians, and if it's delivered as part of the palliative care module FETAC, it gets QQI level 6 accreditation for care attendants. And before they went back, the facilitators and their management teams gave a commitment that they would work in pairs and that they'd deliver 2 programmes in the next year. This was the payback for the investment, and they would have their toolkit and they would be able to replicate the model back in their workplace. This is just the timeline, so it's gone a little bit skewy. The documents were published in July 2014. Then from October until the following March, the facilitators were trained. They took 5 workshop sessions to train all 72 facilitators. Implementation and practice began in earnest about March 2015. A year later, we brought everybody back together to see what had happened, and we're evaluating it then over the summer. So how did we get on? So here on the triangular bit, this bit is about the programme, and we're using Kirkpatrick's model to help us articulate how it translated back into how people got on it. At level 1 of the pyramid here, the reaction that people had to the programme. Overall, it was really very good. People said that the whole approach and programme was good. It held their attention, it was relevant, it applied regardless of the setting that they worked in or the discipline that they came from. They liked the structure, thought it was to the point, they liked learning from each other, and the creativity and the different approach that was used, one person said, was wow. So that was good. Most felt invigorated by it, and they felt enthused, and they felt that they could really take this approach back to their workplace and use it there. But not everybody loved it. One person said it involved group work, and that was something that they really tried to avoid if they could. One person said that this approach was kind of messy, and they preferred a more structured, less creative approach to it. A couple of people felt that the programme is great, but what are the practical steps about bringing it back to my workplace? Have I got the skills myself to be able to facilitate it back there? Plus I work alone. What supports am I going to have to be able to do it? And they were very real concerns. When we got to level 2 and we asked the participants to report on what they had learned on the programme, they came back and said that they learned about the palliative care approach, the 4 domains of care. They learned about what were appropriate specialist palliative care referrals, which was interesting. And they had the confidence now to be able to manage the level 1 care themselves, and then to refer on for advice, for shared care, or for other services. They changed their communication around palliative care in general, which was a good thing. They also learned about the impact that their culture has on their workplace, which was very interesting. And they learned about person-centeredness and some facilitation skills. Right now we're at the green box at the behavioural piece, and we're surveying people to see what behaviour have they changed in their practice since they did this programme now just over a year ago. And then we'll get to the results piece. That's the programme and the outcomes from the programme's point of view. On the other side, it's about the practice. So we kept touch with people, and we collected the stories about how they were getting on, and when they came back to the shared learning event, they told us the things that they had tested and what had worked and what hadn't worked for them. So in the first year, we know that there were 19 programmes delivered. It was a lot less than the 70 that we were expecting, but it was still 200 more people who had been developed as facilitators, who could now go on and spread the news another little bit. Information sessions people found really useful, and they found them much easier to implement. And from the numbers that people gave us, not everybody gave us the numbers that had attended the information sessions, but we know that over 350 people had been exposed to the information about palliative care needs assessment, which was good. What was very clear was that there was no one way. People had to decide what fit in their own workplace. They had tested different things. Some people had split the 2 days of the programme over time. They'd split them into half days. Some people condensed them into 1 day. That's not something that we promote. I can talk about it a bit more if people want. Some people had a day for professionals and a day for care attendants. Some people combined them, and the feedback has helped us now to be very clear about what works for whom, and I can talk to you about that if that is something that you would like. There was a very definite uptake in some work settings over others. Residential care, particularly intellectual disability and care of older people, really took to the approach and to the programme and to using this palliative care needs assessment. Hospitals have started, acute hospitals. Primary care, not yet. It really hasn't taken there yet. There was some very wonderful case studies that were presented on the day at the shared learning event about the impact that this approach had on direct patient care, on individual patients, on teams, and how they pooled resources in a way that they had never done before so that they could maximise the effect of rolling out the programme. One of the consultants had a good way of using the guidance document whenever she was communicating with the nursing homes that were referring to her. So they were all good. And for us on the programme, what was clearly emerging as well was really good measures about how in the future we're going to be able to quantify the impact that this is having in practice. Why is it relevant? So the palliative care needs assessment is there now, and we know that it's starting to be used, and it's really important because you can see here on the circular diagram, people die everywhere. This is about dying in Ireland. People die in every setting, whether it's the hospital, the home, the long stay facility, or in the hospice. Over on the other side, it's data from the UK, and it's from that study that was done in 2010. It was 10,000 patients in 25 hospitals across Scotland. And if you just look at my side, the blue writing here on my side of the yellow boxes, 3 out of 10 people in those 25 hospitals at that time, 3 out of every 10 were in their last year of life, and 1 patient in 10 died during that admission. That makes it really relevant for people in acute care. That's about dying. What about care? I think these are very powerful. These are 2 studies that came out this summer. The one on my side is from the All Ireland Institute of Hospice and Palliative Care, and it was a study that was all Ireland and all settings. Over 500 people reported that their physical care was really quite well looked after at the end of their life, but 51% said that their emotional and psychological care were the least well looked after areas of care. The other one, the circular one, is even closer to home. That is Voices Majam. That is Majam being Mater in St. James's. And 800 bereaved families in about the last 18 months were asked, how was the care of your loved one at the end of life? And over 400 families responded, and they said physical care wasn't bad, but 40% said that the emotional and the spiritual care could have been better. So that's really powerful when it's our patients in our time that are telling us that we can do things better. So what does all of that say in relation to heart failure? And what we've learned overall is probably palliative care needs assessment it's a good tool. It can be used for all patient groups, it can be used by all carers in all settings. So it really is something that can be useful in your heart failure toolkit for the patients that have reached that point of their illness. When I think about the opportunities and the challenges for you in heart failure, there's a couple of things that come to mind. I'm a great believer in including it in the referral form to specialist palliative care. If you put in the 4 domains on the specialist, it really brings it to the mind of the referrer. What is it that I'm referring this patient for? What are the needs, the total needs of the patient? It gives very good data as well to the two services. At the very least, for staff to be able to use the palliative care needs assessment document, they need an information session, and there is no doubt but on your team you have some sort of an education meeting every so often, and one of them could easily be one of these information sessions on the palliative care needs assessment tool. You can download the resources and do that education session yourself, or get the facilitator in your organisation that would do it for you. And I can give you a list of all the people who are now facilitators in the various organisations. I would encourage the 2-day programme, obviously, because the person-centred approach, it applies not only to palliative care but to every other aspect of care as well. It really speaks to the whole patient engagement piece that we're trying to improve at the moment, and to the staff valuing and the staff development piece that is just more crucial than ever at the minute. If any of you are managers, it fits really well with quality improvement methodology, and we have some very nice examples of how we're using it in that way in nursing homes at the moment. And it also links very nicely with just about every one of the national standards for safer, better healthcare, if you want to map it against those. Doing the 2-day programme is a real challenge. I was looking at the delegate list. There are people from 19 hospitals here, and none of those hospitals have yet run one of these programmes. There's people from hospices and from 2 primary care settings as well. But what is clear is the level of interest in heart failure that there is. And for one organisation to be able to release a whole bunch of staff to attend a palliative care needs assessment day might be a bit much. So there could be something in doing it a little bit differently, and maybe taking a few people from each of your organisations and coming together as a heart failure group to run a programme. Or as one of the other groups have done, the hospital, the hospice, the nursing home and the GPs in a local area are coming together, so that the burden is not all on one place to release people. The last point that I would leave you with is about support for staff. And this works best, this 2-day programme works best in a place where you have a work-based education centre. If that is a Centre for Learning and Development in your organisation, or the CNMEs have been wonderful and they're in every region around the country. The last thing, it's all about the people, and I would say that if you are in a position on the heart failure team or on the palliative care team where you are one of the constants on the team, like the consultant, the CNS, the ward manager, and you're not rotating in and out of the service during the year, you have huge opportunity to influence the culture on that team and the way that things are done. And if you change the way that you think about palliative care needs assessment, well then how it's used can change too. Thank you.